of elevated intracranial pressure, headache, and vision loss without mass lesion or an underlying infection or malignancy. As far as I searched, uh, the etiology is unknown. This fact is based on the evidence in 2020. I mean, this year. So the etiology is unknown, and findings are unilateral or bilateral transverse sinus or transverse to sigmoid sinus junction is present in about from 30 to 93% of these patients. There is an ongoing debate on whether venous sinus stenosis is the cause of IIH or a result of it. Treatment includes conservative treatments. If the patient has no symptoms, we can simply observe patients without any treatments. If the patient has symptoms such as headache, we can use medications such as acetazolamide, but conservative therapy is to cure the patients. It is called refractory IIH. In such a patient, traditionally cerebrospinal fluid diversion surgeries, such as shunting, was the mainstays of treatments for refractory IIH. However, in the last decade, venous sinus stenting has emerged as a safe and effective option for treating refractory IIH patients with venous sinus stenosis. In refractory IIH patients, often has a significant pressure gradient over 10 millimeter Hg may be the indication of stenting. Now I'll show you an illustrative case. His chief complaint was tinnitus, and 51-year-old came to my department complaining of tinnitus and headache for 1 month. Opening pressure of lumbar puncture was elevated to 25 centimeter H2O. On an MRI and MRA, no mass lesion was found on an MRI, and the left side of transverse sinus appeared on an MRI. That was shown by red arrow. We performed angiography and Juro AVF at left transverse sinus was found. Main feeders were occipital artery and middle meningeal artery posterior convexity branch. The stenosis was shown by the red arrow. The classification of corneal was type 2B, and the classification of Borden was type 2. Transarterial embolization and stenting were performed for this patient. Intravascular ultrasound was also performed for this patient. The segment of of stenosis showed fibrofatty tissue by intravascular ultrasound. The cause of now I want to have a discussion about the cause of sinus stenosis. In this case, the cause of stenosis was dural AVF, but in many cases, the cause can't be detected, which were called as idiopathic intracranial hypertension. 3 reports of stenting for sinus stenosis and dural AVF and AVM in the past were found. And intravascular ultrasound findings for sinus stenosis in the past is slide. Findings shows fibrofatty changes in 2 cases. And treatments for refractory sinus stenosis, summary of refractory sinus stenosis, I mean, among 18 patients, stent treatments were performed for 15 patients, and shunting was performed for 3 patients, and 3 patients had restenosis, and they were treated with stent.
Second stent?
Excuse me?
The patient had restenosis. Did you put a second stent in?
Yeah. Stent or balloon expansion of.
Oh, okay. Right.
Conclusion: the intravascular ultrasound findings showed fibrofatty change in our case and all reports, which may mean the etiology is some change on vessel walls in tumor due to hemodynamic change. Stenting may be effective for pseudotumor cerebri syndrome with sinus stenosis, but further data accumulation is indispensable, I think. Thank you. That's it.
In the vein.
Wait, I know what it is, but who does it?
He does it.
Oh,
A neurologist. He's a neurologist who does
okay.
vascular neurology. So this is
Okay.
a subspecialty.
Vascular
Very good, Dr.
Excellent.
Kashimura. We have some questions.
Can we get, can you empty your screen? Can you clear your screen, please? So we can see your face?
Yeah.
Or do I do that? Let's see.
Let's see. Let me. Yeah, there we go.
Very good.
Well, I enjoyed this very much, Dr. Kashimura.
Thank you.
We have many patients with pseudotumor and benign intracranial hypertension. Right now, I have a patient that I just saw last week who, because of the virus, the pandemic has gone back to Palo Alto or around Stanford to be with her mother. The mother is a nurse practitioner, but she's a student here, 21 years old, student here at GW, and she has become my patient, and I'm treating her with Dimox. And of course, we did MRA and also MRV. We did a CT angiogram as well. No evidence of sinus thrombosis, no, but she could have, of course, something less. But I had a question for you. Virtually all of my patients with pseudotumor are obese. They are young. They tend to be very young, 20s, between 20 and 30. and frequently have had some babies, but they are, I would say, the whole group is obese. Obesity seems to be playing a role. Young female with sometimes frequently some children. They have been pregnant. Is this different from the Japanese experience, I wonder?
Same, I think.
Because your patient that you presented came in with tinnitus. What made you think that this could be pseudotumor cerebri? I mean, just tinnitus, and you didn't describe her. I don't know how much she weighed or any other history. The case you presented. What made you, I mean, and how do you explain the tinnitus with the pseudotumor, with normal neurologic exam and no papilledema?
One, we diagnosed him as pseudotumor cerebri at the first time because the opening pressure of lumbar puncture was elevated without any mass lesion. So,
right. Now, you know, 250, which is 250 millimeters, is, you know, is not, to me, that's elevated, but many times my patients are 300, 350. The fluid actually, when I do the spinal tap, the fluid goes across the, it goes across to the wall. 250, I see sometimes when it's difficult to do the spinal tap. Was the patient sitting or lying down? Because when you're sitting, the pressure is always increased. So 250 is, to me, it is elevated, I agree, but not critically elevated. And what was the mechanism of the spinal tap? How do you do it with how do you do it in your lab? Is the patient lying down or is the patient sitting?
Lying down
Right.
on his left side.
Okay, and what was the closing pressure? So the 250 was opening pressure. How much fluid did you take off?
10 from 10 to 10 cc, around 10 cc.
Yeah, because of course when you do the lumbar puncture, it's not only diagnostic but therapeutic. I have many patients that are chronic. They're chronic pseudotumor, and I work with the ophthalmologist, especially in the Washington Center at GW. We have an ophthalmologist, Dr. Barnes, who automatically evaluates the patient. We do fields, regular fields, and I use the acetazolamide or Diamox. But you're absolutely right that you have to think, and this is for the others, you have to think about venous obstruction, some kind of obstruction, and you have to go and do MRA, and I always do also venous study, etc. But I liked your presentation with the emphasis on the radiology. Our patients here in America they tend to be obese. We have a big problem with obesity, and not unusual, 300 pounds. So do you have any idea of what is the relationship between the morbid obesity, the fecundity, and the pseudotumor cerebri? Do you think there's a relationship, or what is the relationship? Do you think it's all vascular or endothelial?
Yeah, I don't know if obesity is the cause of pseudotumor cerebri or result of pseudotumor cerebri. I don't know, but pseudotumors, and in addition, the stenosis found in excuse me, the stenosis found in pseudotumor cerebri is also a known mechanism, but I think uh, because the pseudotumor cerebri can affect the vessels, I mean sinus. I think that the pseudotumor cerebri can have some effects about other vessels that can affect obesity, I think.
Yeah. Well, I agree with you. And in my patients that I work up and evaluate for pseudotumor, I like to do the venous evaluation all the time. Many neurologists in here don't do it. They just stay with the MRI. They do the spinal tap and they treat with the Diamox. But I like to take the next step. So I totally agree with you about looking for venous thrombosis or venous occlusion or some kind of venous problem. Some of these patients can have also bleed. They can have a stroke and a bleed, and they can even have seizure subsequently. So I think it's more serious than people think. They call it benign, but this is not benign. Do you agree that the word benign intracranial hypertension is a wrong term? I mean, that's
I agree.
my opinion. What do the others think about this? What,
I
Dr.
also think that is wrong because it can cause also vision loss, and that is no benign at all.
Yeah, I think the benign intracranial hypertension is opposed to those intracranial hypertension caused by malignant tumor. So that is why the name came, but actually this condition can cause malignant result. So
Sure.
yeah.
Yeah, it gives some neurologists gives them a false sense of security, and they don't pursue it. They say, oh yeah, it's just right now I have a patient, even today, the mother is calling me and she's so nervous because she's got some visual problem, and we were planning to do further testing here, but because she's a student and because of the virus, so she went back to California. So I had to find somebody at Stanford, actually, the Stanford clinic to see her. I have her on Diamox, high doses of Diamox. She weighs about 240 pounds. She's 5'3", 5'4". No children, and she's a student. She's one of the students at George Washington University. In fact, I have to call her today to see how she's doing. Thank you very much. I liked your presentation. It's very focused, and it's a good idea for the doctors because you could spend so many hours on this. But I like what you did. It's very focused. Dr. Stein, anything?
Is there any problem with reabsorption? Is there also a possibility that the spinal fluid is not reabsorbed fast enough?
In this case, do you mean refractory case for refractory patients?
Well,
And that
I'm
depends
really
on
naive, but you have the resorption of the spinal fluid. Isn't there sort of a cycle?
Yeah.
That's basically the shunt takes care of the reabsorption. My question is there a problem with reabsorption?
that depends on the findings of angiography because, for example, in this case, he has he has cortical reflex of venous flow. It's called dangerous type. 15% of patients with these findings can have bleeding per year. So this is very dangerous finding. So stenting or arterial embolization are dispensable for this patient.
Did you say the patient had arterial venous malformation, an AVM? I thought you in your presentation. I thought you said there was an AVM. Am I incorrect?
Patients without cortical reflux can be treated. Yeah.
This
That's right.
was venous. This is a venous stenosis or venous obstruction, different from arteriovenous malformation. That's a different problem. When you do embolization, arterial embolization, what do you mean in pseudotumor cerebri? What do you embolize?
Please show me my slide again. As far as I searched through the databases such as PubMed, Web of Science, and Cochrane Library, there are 3 cases of pseudotumor cerebri with 0 AVF or AVM.
But these are all venous. It's all venous. So it's all venous. And then
I think at least at this point, there is no sinus stenosis caused by 0 AVF is considered as pseudotumor cerebri according to the past reports.
Right.
I think.
But that's very rare. I mean, those are rare, very rare cases. Dural venous and AVM and so forth is a rare condition.
Yes, but I think
your patient came, and I noticed the chief complaint was tinnitus.
Right.
Are you suggesting that tinnitus is maybe one of the presentations of pseudotumor?
No, tinnitus was caused by 0 AVF, I think.
Okay.
And
So this is an unusual case. Did you write this up? Did you publish this case? Were you able to publish this case in Japan? It's an interesting case.
Simple one case report can be accepted, I think. So
Sure.
Case accumulation is needed, and I need to add the systematic review of articles in order to pass the in order to be published, I think. So
Well, we have quite a few cases here, and I may refer them to you so that you could at least think about them. I have many chronic cases, intractable, and it's frustrating because we do ophthalmologic evaluation, visual fields. I do repeat spinal taps, and they still have symptoms. So we have a new patient just came in. Anyways, thank you, Dr. Kashimura. I like the presentation. Excellent.
Thank you.
Here's a patient.
Yes, thank you, Dr.
This is
Very
a
good
male.
presentation, doctor.
Excellent.
This is a headache, patient with headache. and let's see, 39-year-old, and unusual because it's a man, William, male, and the patient is on diltiazem. All of you know diltiazem. You're familiar with Maria?
Of course.
Calcium channel
You can
blockers.
call.
Yeah. And patient is also on Xarelto. I'm not sure why they're on Xarelto, maybe cardiac problem. So I'm not sure why. So let's go and let's see. It doesn't give you much. I guess they saw an internist. The internist sent him here. 39-year-old with headache. So let me go in room 2. So I'll take you. I'll take all the students. Yeah, 6 of you. Okay. I'm taking you with me.
Thank you.
Mary, thank you.
You're welcome.
So I'll go.
Okay, I'll let him know you're here, okay?
Hi, Paul. Fine, we got some bagels for you. Go up, yeah. Hello. Fine, thanks. You must be William. Do you mind if we have the 6 students